So the final session of the day is on laboratory diagnosis for malaria elimination and health security. This session will highlight the critical role of laboratory diagnosis in managing malaria and its connection to a country's broader health security. We will draw on learnings from the Trilateral Malaria Project and other experiences in the Asia-Pacific region. So the chairperson for our session this afternoon is Deputy Secretary Ken Wai, and our co-chair is Miriam Carter, Counsellor-Health, Australian Department of Foreign Affairs and Trade. Our panellists for this evening, for the last session, Professor Gao, Chair of the National Malaria Expert Committee, China. We also have Mr. Ernest Velemu, Manager of Quality Control at CPHL, National Department of Health, PNG. And finally, Dr. Ome-Kaius, Head of Vector-Borne Diseases, PNG, IMR. Our moderator for the final session is Professor Leanne Robinson. So I'll ask the panel members to take the stage. And I just want to give a quick sort of update. So we anticipate that the Prime Minister will arrive at 5 or maybe slightly before. Hopefully, the panel session will run as planned and we will have everything finished by 5 o'clock. Should the Prime Minister arrive earlier than we expect, we will just pause as the procession brings him in and he will be seated at this front table. And then we will continue and then he will be welcomed up to give his closing remarks. If he arrives on time, hopefully we would have finished and then we would just be waiting around for him. The other scenario is that we finish and we're still waiting around. I want to advertise that there's a craft market just outside the foyer, so don't go too far, but I do encourage you to have a look at some of the craft and the art that's out there. So look, we've got about 3 scenarios of what might happen, and you will just have to bear with us and we'll take it in our stride. But thank you, everyone. Thank you, everyone, and we will begin the session, and I'm going to pass it over to... So I'm going to pass it over to the chair. Thank you, panel.
Thank you, Chair, the heads of delegations, summit leaders, the sponsors, technical experts, presenters, the moderator, the panel, ladies and gentlemen. I am honored to speak to you this afternoon about the Trilateral Project, a remarkable collaboration between 3 governments, the Government of Australia, China, and Papua New Guinea, generously funded by the Australian government. This initiative exemplifies the power of international cooperation in addressing critical public health challenges in the country. The Trilateral Malaria Project supports the Papua New Guinea's National Malaria Control Program, managed by the National Department of Health. This collaboration creates a platform for key institutions from all 3 countries to share knowledge and expertise, enhancing our collaborative and collective efforts to combat malaria. The Australia, China, Papua New Guinea trilateral collaboration on malaria commenced its first phase from 2015 to 2018 and embarked on phase 2 in January 2020. The overarching goal remains clear, and that is to strengthen the public health system in Papua New Guinea, contributing to malaria elimination through enhanced trilateral cooperation. The Trilateral Malaria Project has two primary objectives, and that is, number one, in improving the capacity of the health system to reduce malaria burden in PNG, and two, fostering a transformative partnership between Australia, China, and Papua New Guinea to address health security challenges through mutual learning and enhanced cooperation. Let us delve into three significant outcomes achieved through the collaboration. Firstly, the health system in Papua New Guinea is improving its capacity to reduce the burden of malaria. We have strengthened our laboratory system with support provided to both the Central Public Health Laboratory, or CPHL, and the Papua New Guinea Institute of Medical Research laboratories. One by the malaria PCR scientist at CPHL undertakes invaluable malaria work, providing additional capacity for national laboratory strengthening activities. Two, laboratory diagnostic capacity building focuses on malaria microscopy, considered the gold standard for malaria diagnosis in PNG. The Trilateral Malaria Project remains the main supporter of microscopy training and accreditation through CPHL's External Quality Assurance Program. Three, the Laboratory Information Management System has enhanced with the engagement of Christian Technologies in 2021 to develop a functional laboratory information system. Four, laboratory systems strengthening includes supervisory visits to our provincial laboratories, a crucial component of the national EQA program. And these visit opportunities for CPHL to monitor and train and assess provincial and district laboratory staff and facilities in the country. And finally, laboratory reference has been codified through the establishment of Malaria Slide Bank by CPHL, supported by the National Institute of Public Health. Initiated in 2016, the Malaria Slide Bank ensures compliance with WHO standards for a national reference laboratory. Secondly, the National Department of Health malaria policies and practices are now based on quality standard analysis and interpretation. These are aggregated by gender and informed local research. And notifiable initiatives include malaria surveillance sentinel sites. The sentinel surveillance is a vital tool for informing public health decision making. The project extended to its support for to 4 additional sentinel sites in the second half of 2022, bringing the total to 8 supported sites managed by the STRIVE PNG program. The molecular hub established in 2019 monitors the vector-borne pathogens and anti-malarial resistant markers, or drug-resistant markers. The collaboration brought together partners from CPHL, NMCP, the School of Medicine, and the PNG Institute of Medical Research, capitalizing on respective strengths and leveraging the limited resources. Lastly, selected provinces have demonstrated improved capacity to prevent, detect, and respond equitably to malaria. A key focus area has been monitoring and evaluation capacity development in the West Sepik Provincial Health Authority. The Trilateral Malaria Project stands as a beacon of what can be achieved through collaboration, shared experience, and unwavering commitment. Together, we are making strides towards a malaria-free future for Papua New Guinea, strengthening the public health system and setting a powerful example of international cooperation. Thank you, ladies and gentlemen.
See which one's going to work for us. Thank you very much, Deputy Secretary Ken Wai, Chair of this session, for those opening remarks about this really important final technical session of our summit on laboratory diagnosis to support malaria control and elimination, and the role that the Trilateral Malaria Project has played in that in Papua New Guinea. Just to really quickly orient you to how this session is going to work, we're going to have an opening presentation by Dr. James Kelley, the Regional Malaria Advisor for WHO Western Pacific Regional Office. And then we're going to have some short presentations from Ernest Velemu from CPHL to share perspectives from CPHL around malaria diagnostics, and then from Dr. Maria Ome-Kaius from PNG IMR on malaria diagnostics at the Molecular Hub. And then we'll hear from Prof. Gao Chi, Chair of the National Malaria Expert Committee in China, to really hear about China's experience with malaria elimination and how diagnostics really supported that. And then we'll open up for some panel discussion and Q&A. And I'm just letting you know we may need to pause during the session to welcome the Prime Minister to join the session, and then we'll continue the session. So thanks very much, Dr. Kelley.
I'll keep it short. We're under a bit of pressure now, so we will be flexible. Good afternoon once again. And what I should have done in the last session, I'll do now, and that is to thank very much the PNG government for inviting me to attend this wonderful gathering, and also the APLMA Secretariat for all of the amazing work and months of preparations to make this happen. APLMA is a key partner with WHO, and as our RD mentioned this morning, it's a very, very strong partnership that I think this is sparking a new and invigorated relationship this week. Next slide. I will keep it short. This topic really is important for regional coordination, that is malaria diagnosis and quality assurance, particularly for the quality assurance side. So I would like to just talk a bit on, I'll skip the guidance development since we're a bit pressed for time, but mentioned as we all use tools and the quality assurance scheme that WHO is helping to coordinate. So for this, I think we can skip this slide, but I just wanted to mention, I think was mentioned earlier in the last session, the preferred product characteristics for malaria. WHO is part of its guideline development process is coming to partners, private sector, and trying as part of the preparation or expectation of what is needed in the pipeline, putting out these preferred characteristic product characteristic documents to support the process. WHO regularly publishes these documents to help guide the overall landscape, and there are not just for diagnostics but other areas within the global technical strategy. Next slide. So really the core principle of malaria diagnosis is to ensure early and accurate detection, to guide treatment, that's the purpose, and to save lives. So accurate diagnosis for malaria is using the standard tools that we have. For clinical management, that is microscopy and RDTs, and this helps to ensure rational use of the antimalarial drugs, avoiding overuse or misuse, which can lead to drug resistance. So that's what we want to avoid, and that's why we want to properly, accurately diagnose malaria. Next slide. As we all know and has been discussed even by the chair, microscopy is the gold standard due to its specificity and sensitivity, but more importantly because it allows for the quantification of parasite load. And this is essential for assessing severity of disease, but monitoring treatment of drug efficacy, which is critical in particularly in our region in the GMS. In remote settings, microscopy is, of course, more difficult to employ due to capacity and maintenance costs, and it takes a little bit longer to get the results. But RDTs, as we all use widely now, both in rural and urban settings, are quick and easy. They're particularly useful in remote areas with limited access to lab facilities. The downside is their variability in quality and stability, and limited ability to quantify parasite load. Next, please. So just to show you, WHO, as part of its mandate, is producing guidance documents to support guidelines, training manuals, quality assurance protocols, etc. So this is something ongoing and updating as new guidance comes out. Next. So I want to talk just a little bit before turning it over about the quality assurance for malaria diagnosis, because this is quite unique and a role that WHO has been playing for many years in the region. It's obviously vital to ensure reliable and accurate malaria diagnosis. WHO coordinates the external competency assessments for malaria microscopy across the regions, both primarily actually across the globe, in Africa, CIERO, WIPRO, and supporting the regional external quality assurance programs. And this is facilitated through our collaborating center, Research Institute of Tropical Medicine in the Philippines, whereby twice a year they're working with national reference labs to send slides and sort of test their ability to properly diagnose these slides. WHO is also currently engaged with countries to strengthen the national slide banks for their own national quality assurance programs. And I think this is really a transition that's happening recently to move away from the external quality assurance, but strengthen capacity in countries to conduct their own national quality assurance programs. Next. So just one slide here, a couple more. The near-patient diagnostics for G6PD is clearly important for vivax elimination and safe administration of primaquine and tafenoquine to prevent relapse. They do share some common features. I apologize, I'm not an expert in this field, but we fortunately do have experts up here that can speak to more of what is in the pipeline and what's available to do this, to detect the deficiency status in patients in the field. But of course, there have been challenges with the adoption and rollout in countries, and we're here together today, I think, to discuss some of the ways forward and how to better roll out G6PD testing. Next. So my last slide here really is, I think, mentioned earlier by Stefan, the threats map for he mentioned it in the context of insecticide resistance, but this was developed in 2017 as part of an initiative by WHO. It's an online interactive data visualization platform to track key biological threats in the malaria space. So relevant to the session on diagnostics, I think there are two indicators here that are worthy of tracking and continuing to build the database, which, to be honest, it's a bit limited and it's not ideal for policy making at the moment, but it's a way to track both monitor drug resistance through genomics and the HRP2 and 3 deletions, which could clearly and has been affecting HRP2 RDTs, particularly in sub-Saharan Africa, but also in our region. Next. So I think this is the last, it's a little bit truncated, but the point of this was to comment on the PF-HRP2 and 3 deletions that is clearly important and important for diagnosis and the purpose of guiding treatment. So in response to this in 2019, WHO developed a response plan to sort of tackle this issue about HRP2 deletions. And the plan includes part of what's being done with the health threats map, the malaria threats map, in mapping distribution of these deletions, but also building international networks of labs for molecular confirmation and supporting countries in selecting new RDTs as appropriate, and working with commercial manufacturers. And finally, last slide, is just a call to action for all of us, malaria leaders, to maintain strong collaboration among partners, programs, and other sectors to ensure universal access to quality-assured malaria diagnosis for prompt and effective treatment, and the integration of the new tools and methods when they become available. Thank you.
Thanks so much, Dr. Kelley. That was a fabulous overview and really perfect to set the scene at the regional level for the two talks that are going to follow next. So I'd now like to welcome Mr. Ernest Velemu to deliver his presentation and really talk about some of those quality assurance frameworks as to how they've been applied here in Papua New Guinea. Thanks, Ernest.
Thank you, Prof. Lian and distinguished guests. Okay, the topic I will be presenting is importance of diagnosis, laboratory needs, and challenges in laboratory management in low sense settings. Next slide. Okay, for this slide, I think everyone in this room is all aware of the importance of diagnosis. But I think what can be appreciated from this slide is diagnosis is key to all the key interventions for malaria diagnosis. Next slide. Some of the unique challenges we go through in PNG in delivering the laboratory services, many of these are covered in the presentations yesterday and today, this morning. But I like to point out few things. The second, in delivering the laboratory services, the second point here, lack of public health laboratory governance structure, mainly in the PHL level. At the national level, we have the CPHL. We work closely with the public health diseases, but at the intermediate level, at the PHL level, that governance structure for public health laboratory is lacking a little bit. In the most recent meeting we had with the lab managers, a question was asked how much they engage with the public health interventions in their province, and the answers given were very not convincing. It gives a sense that there is a lack of their involvement in the public health issues at the PHL level. And of course, there are reports, WHO reports, that the coverage of WHO-defined essential care is lacking in many of the health facilities, or stagnant or have declined. And this gives a challenge for us to produce, and it can impact the accuracy and the reliability of the tests that we perform. So these are some of the challenges we face in delivering the laboratory services in the country. Next. And I will tie this to the project that our Deputy Secretary has alluded to. One of the key strategies that has been very successful is the partnership and collaboration. One of the projects that has been very, very successful and brought us the key institutions in the country, the academic, the research institution, and the government institution like CPHL, is through the trilateral partnership. Before 2016, we were working in silos. But when the project brought us together, we were working together as one unit, and where we were weak, we were strengthened through the strengths from other institutions. And of course, the capacity building that we learned through the international engagements, like for instance, China and Australia, has really built our capacity in terms of molecular testing at CPHL, and using that capacity to build our national slide bank. Not only that, it also allows us to form the molecular hub between the three institutions, the University School of Medicine, Research IMR, and CPHL. The molecular scientists came together and they were designing assays that could be transferred to CPHL for routine use. And of course, we talked about community engagement. In the delivery of health services, there are challenges we face, and communities have their contribution in delivering the health services in the difficult circumstances we face. Next slide. I think the previous slide, there was a previous slide to next. I think we are missing one of the slide here, but the slide that is missing gives us the data of the, Dr. Kelley mentioned about the program WHO coordinates throughout the world, the external competency assessment. Prior to around 2011, 2012, there was gap analysis by WHO, and the conclusion was that the microscopy capacity in the country was below international standards. So we had to build those capacities. And prior to 2016, before the trilateral program, there were only one level 1 certified microscopists in the country, WHO certified. But through the support from the trilateral malaria project, the current we have is there are 17 level 1 in the country and 22 level 2s in the country. And since 2016, there were 101 microscopists assessed through the external competency assessment the WHO coordinates from 49 sites. And currently we have 17 level 1s and 22 level 2s. And they are distributed right across the country. Unfortunately, I cannot, the slide is not here to show you the distribution of those levels throughout the countries. But there is an opportunity for provinces to embrace on and use those capacities that are in the provinces to strengthen their microscopy work in each of the provinces. And the third strategy that we've been running is the quality assurance program. There are potentially 80 malaria microscopy facilities in the country. And this is from last year's EQA data. 55% are providing malaria microscopy without EQA coverage. We don't know, at the time of this analysis, whether this 55% are all functioning or some are not functioning. And 28% are providing EQA microscopy services with adequate EQA coverage. And 16, they either participate once, so we regard that as inadequate microscopy service provided with inadequate EQA coverage. So those are some of the basic things that are happening in terms of quality assurance. But I want to re-emphasize back on the partnership. Through the capacity building, we are able to build the National Slide Bank that can be used for training and providing the EQA program in the country. And the molecular hub using all the scientists in each of the institutions to build or develop the assays to diagnose other vector-borne diseases. Those assays are transferred to CPHL for routine use. I think that's all.
And here we go. That was great, and excellent insight into where things are at, both at the national level but also at the provincial level. And I think we might touch on that again in the discussion. But for now, I'd like to welcome Dr. Maria Ome-Kaius, who will present on some of the points Ernest touched on in terms of the collaborative work that's been happening at the Molecular Hub. Over to you, Maria.
Thank you, Leanne. Good afternoon, everyone. So this afternoon, I guess we've heard about the microscopy side of the capacity that's established at the CPHL, and this afternoon I will share with you where molecular diagnostics is at for PNG, especially in relation to the malaria elimination efforts. Next slide, please. Yes. So I guess before I move into discussing a little bit about the establishment of the molecular hub, what can we use the molecular data for? So the data generated from molecular diagnostic tools can be used for confirming what the malaria case might be that's detected by malaria rapid diagnostic test in the fields. Additionally, molecular diagnostic tools can help us identify false negatives that was alluded to earlier today, that are often a result of of RDTs not being able to detect the infections that are below its limit of detection. And these infections are often of low densities, and molecular diagnostic tools help us to kind of pick up these infections that we would not otherwise pick them up from the microscopy or malaria rapid diagnostic test. And this data is important to accurately help us determine the true burden of malaria infection and transmission across the country. This data can guide decision making, especially in terms of kind of prioritizing where the resources can be allocated to, or the areas which may be affected the most. The molecular assays are the most sensitive tools, as we know, compared to microscopy and malaria rapid diagnostic tools, and they are used for speciation, and this is allowing us to determine what the species the patient might be suffering from. With the molecular diagnostic data, we are able to also monitor the incidence of the malaria cases and be able to signal an impending outbreak. In an outbreak setting, it can also provide data on the predominant species that is driving the transmission, and in terms of that can guide us into the treatment allocation. Finally, it helps us to identify and monitor emergence and trends of anti-malarial drug resistance. Next slide, please. Now in PNG, the capacity for molecular diagnostic existed only within PNG IMR for malaria research. There was technical expertise, infrastructure, and laboratory setup that was well established, and the capacity was only for detecting or conducting pan-species PCR, meaning just screening for any Plasmodium species present, but also for species-specific PCR. However, about 5 to 10 years ago, through the Trilateral Malaria Project and the STRIPE PNG project, this capacity was expanded through what we now refer to as Molecular Hub. It's a collaborative research laboratory space that is situated in in University of PNG at the medical school. TMP, as Deputy Secretary has already given you the context of, was a partnership between 3 countries, Australia, China, and PNG, all coming together, putting efforts together to address the malaria problem in the country. And a key focus was on strengthening the surveillance systems with improved diagnosis. Australian government supported with the funding, China supported with the technical expertise, and PNG stakeholders supported with the implementation and the expertise as well. Strive PNG also supported by DFAD, but through Center of Health Security, focused on integrating near real-time VBD surveillance, mapping this and response network. What was important was that they employed a partnership approach, and that's already mentioned today by Deputy Secretary and Ernest. It was involving various international and domestic partners with active involvement and participation by the National Malaria Control Program. And I want to acknowledge here late Mr. Makita. Under his leadership and guidance as the program manager, this made this partnership stick together and work well together to better support the program with its priorities. The partnership approach enabled mutual understanding and respect between the partners and allowed for resource sharing and expertise sharing as well. The Molecular Hub was established, as Ernest has already mentioned, through the resource sharing between partners like PNG IMR, CPHL, and School of Medical Health Sciences, plus the Bennett Institute. Next slide, please. To date, the Molecular Hub has established high throughput molecular testing capacity. In addition to the pan-species PCR and the species-specific PCR that I mentioned earlier, there is now capacity to do P. falciparum C580Y PCR, which is targeted at monitoring markers of drug resistance, while the genome sequencing for molecular resistance is still being set up at the hub. Apart from malaria, the lab has also capacity now to test for arboviruses, including dengue, chikungunya, Zika virus, Ross River virus, and Burma forest virus. With this capacity established, it was relatively easy through additional funding support from the DFAD Center of Health Security to support in the establishment of emergency diseases molecular testing for COVID-19 in the country during the pandemic period. In a similar way, the establishment of African swine fever with partnership with ANACIA. In addition to the molecular capacity establishment, HUB is also now established to conduct the serological testing for malaria, COVID-19, neglected tropical diseases, and vaccine-preventable diseases. Important for the hub is the continuous cross-learning between the various partners, both domestic and international, through training, mentorship programs where experiences, expertise, knowledge are shared between the partners. Next slide, please. So while some of these capabilities of the Molecular Hub are driven by the research programs and aims, research projects have their aims and objectives, much of the molecular diagnostic data generated is guided by the priorities of the NMCP and the key partners. So this is just an example of where in a molecular use case workshop setting, different molecular diagnostic tools and the kind of data that can be generated were discussed with the key partners, including the NMCP and various partners from the provinces, including the PHAs and the CPHL. The key task during this workshop was to identify tools that they were considered of high priority and rank them according to their relevance and feasibility. So from this workshop, detecting drug resistance and detecting HRP2 tree-based rapid diagnostic failures as the highly relevant and feasible, especially during this time where Papua New Guinea was still in the control phase. So with regard to the diagnostics, so the response from that meeting, with regard to the diagnostic test failures, these have been captured into the STRIVE TMP programs, and it is involving the collection of invalid malaria rapid diagnostic tests, and this data is now routinely fed back to the National Malaria Control Program. In terms of the drug resistance, the establishment of C580Y was prioritized over the whole genome sequencing, and that is now underway and generating data to kind of screen and establish the data to see what the burden of drug-resistant markers are. Next slide, please. So this is another example of how the molecular data can be used, and this is a case that was referred to earlier during the day, an outbreak of malaria that was seen in Simbu province in the Highlands region, and that through the molecular monitoring of the incidence of malaria was able to pick up the signal for malaria outbreak, and through the molecular diagnostics established at the MOL hub, the data was used to confirm the outbreak, but also determine the predominant species that was driving the transmission, and that was guiding the kind of treatment that was implemented during that outbreak. Next slide, please. So this is one of the some of the discussions that happened over the past 2 days, but one of the examples of the use through this partnership with STRIVE and trilateral malaria projects, bringing all the partners together. In a recent Global Fund WHO midterm review, it was identified that there were issues with reporting in the current PF-PEN RDTs that are currently being used. And a recommendation was put forward to the National Malaria Control Program to consider switching to PF or PV RDTs. With this in mind, there was a request to confirm using molecular diagnostic tools if the mixed infections that are reported at the facilities using the malaria rapid diagnostics were truly mixed infections. So from here, you can see in the bar graph, it was supposed to be a different color, kind of that 25.5% was supposed to be in purple, but that's the mixed infections detected by RDTs. And you can see below in the pie chart, you can see that majority of 83% of those infections that were identified as mixed infections by RDT are actually just P. falciparum monoinfections. So this confirms the diagnosis of P. falciparum, but it also provides the evidence that alternative malaria RDTs should be considered. Next slide. So I guess in summary, molecular testing capacity, it's still in the research means, it's still in infancy, and it has, there's been progress made, but it provides that cross-learning between the different partners and guided by the National Malaria Control Program and the key partners. We are gonna be making one step at a time. Progress is slow. We have to be mindful that whatever the diagnostic tool that we want to implement must be relevant and must be feasible and is implemented at the right time. For instance, scaling up of high throughput molecular assays will obviously be costly and are obviously not field deployable. So it may be relevant at the national level. So we still have this diagnostics of malaria, rapid diagnostics and microscopy that we still rely on. And molecular may come at a time when we might need it, maybe near malaria elimination stages. With that, I want to, last slide please, say that all this work, the establishment of this molecular hub, the partnership and all of that was made possible through big group of people and institutions that made it possible. Thank you, everyone.
Thanks so much, Maria. That was excellent. Now, I'm just going to pass to Pam. No, keep going. Okay, sorry. That's moving feast. So thanks so much. I'm now going to pass the microphone to Prof. Gauchi to share with us, his wealth of experience from malaria elimination in China, particularly perspectives on, the role of diagnostics and laboratory diagnostics in achieving that.
Okay, thanks. Give the opportunity to share some of the experience we designed, which tools for the parasite test during the different setting. I remember in 2008, we prepared the National Malaria Elimination the working plan. During that period, according to WHO documents, all of the suspected malaria cases, they will be receive the parasitoid test before take the anti-malaria drugs. It means we need to strengthen ability for parasite testing in the lab. Now we turn back to which tools, because WHO recommend microscopy or RDTs. And during that period, we think about which one is more cost effective. And during that period, we have no local product of the RDT. This should be all outside of China. And in China, domestic strain of the parasite is Vivax malaria. And in outside China, the PF specific is more popular and cheap. The pan-specific RDT is more expensive. And the sensitivity for the PV is not as good as for the PF. So in this way, we didn't want to select RDT because from manufacturer, import to China, transportation from central level to village level, already 1 year passed. So the RDT only about two years. So we have to order again and again. We cannot confirm that we can order this for malaria elimination. So in this way, we support using microscope as a major tools for the malaria elimination. So even in one province, more than about 2,000 microscopists lab established from each level up to community level hospital. So even that time, we still have some villages that have no tools. So we asked them, if you found the case, you can pick up the blood and send the blood to the lab. They can test for this. So when we do for this one, we'll find the challenge is quality control. Because for different levels, the scale is a total difference. So how we can make sure the high quality for laboratory diagnosis? We established the reference lab. So the national level and in each provincial level, we established the quality control systems. So all of the positive cases, we need to double check the slides. And we also select 5 to 10% of the negative slides to double check for the quality control for this. So even at that time, we do not using the molecule test as a main tools for malaria elimination, because we already know Sri Lanka certification at the 2012 without PCR, so there's still certification. So we, in the central lab at the provincial level, the reference lab, we still keep the molecule test ability. However, the molecule test we're only using for some specific purpose. For example, if we're using for the PCR to classify different species. China have a PF, PV, and Plasmodium malaria. We do not have a Plasmodium ovale. However, for Plasmodium ovale, some strains on the microscope is similar to Plasmodium vivax. So we're using the PCR tools to classify if the Plasmodium ovale, we immediately confirm that this is import cases. So we do not do the foresight response. So we save the money, save the human resource. If we confirm the vivax, we need looking for this is import cases or local transmission. So this is cost effective. And we're also using this for the drug resistant test because more and more the import case from Africa, some of them have even drug resistant to artemisinin. So we also do the vector survey, so using for insecticide resistant test, so specific only for molecule test. And we never using molecule test for the malaria elimination tools. Once one of the university developed one of the PCR tools, they said there will be 10 times sensitivity than the normal PCR. And they want to do the field survey, the active survey. We didn't agree because when they do the field survey, they find a lot of the positive. How you confirm this is a real positive or false positive? Because normally we already know if the more sensitive, it means more false positive there. So we have no quality control. How to control this PCR result is correct or not? So in this way, we forgot for this. So after that, the laboratory test is very useful for malaria elimination in China. Several years left in 2017. The last engineer cases in China is 2016. So the situation changed because in most of the community level, they cannot find the malaria case for a long period. So maintain the quality and the microscope scale is more difficult, even with training again and again. Some microscopy, after graduate at the university, they never find the case, only training. So this maintain is a big challenge for us. And another challenge is most of case now is not the locally, they the import. So when the import cases, they want to looking for the big hospital when they got a fever. They do not want to go to the village level or community level. So in this way, if we still keep the microscope at the village level, at the community level, is not cost effective. So we need to change this one. So during that period, the one or two the company in China, they can product the local product, the RDTs. And they modify, and for P-Vivax is more sensitive as before. The cost is reduced. And they can immediately from the company to the field. So we need more time can be using. So in this period, we modify our national malaria elimination standard. So we using the RDT to instead of the microscope at the low level, at the village level, at the community level, we only using RDT. However, in the higher level, we still keep the microscope because many of the import cases, when they go to hospital, sometimes they become the severe malaria cases. We're using microscope, not only can be confirmed this is positive or not, and according to clastemia, we can also guideline the treatment result. So in this way, is more than very useful. And however, we still keep the microscope and the PCR ability as the reference level. Even that time, we already have the ability to keep the molecule test at the district level, but we didn't agree because establishability is easy. The quality control and the contamination problem at the low level is a big challenge. So we only keep it at the high level. And mostly we're using for another ability. It means for import cases, we can using this classify where they come from. So we're using the PCR the technicians to test some cases. So according to the epidemiological survey, it's very difficult to classify this is import cases or local infections. So we're using the molecular method can classify this is the Africa strain, this is the Southeast Asia strain, this is the local strain. So this is for this way we can say. So finally, I just say, molecular method is very useful for malaria elimination, but there is not necessary for elimination. If in the low resource countries, even without the molecule ability, we still can reach the goal to elimination. Okay.
Thank you very much, Prof. Gao, for those remarks. I think incredibly pertinent to the discussions of this session, but even to the discussions of the past 2 days, I think, where it's that similar message of having the right tools, in this case, the right tests, at the right level of the health system to answer the right questions to inform decision making and the sustainability point that I think you picked up, particularly about establishing something like molecular diagnostic assays at the provincial level. The difficulties and the challenges with sustaining that over time, I think maybe provide some really important lessons for other countries and partners in the room. So I think I've still got the nod to continue. Okay. So I'm just going to ask one question of each of our speakers, and then I'm going to open it up to the floor. So if any of you are starting to think about questions, please be ready. But Dr. Kelley, I just wanted to first come back to you and based on your experience and role across the region, really ask if you have any insights to share around what components or features of reference laboratories and quality assurance programs have you observed really to be most critical in the different phases in control or elimination and in particular maybe in supporting the transition from control to elimination?
Thank you. So national reference labs are very costly. So funding is very important. Sustained financing is clearly important to maintain a national reference lab. Second, I think for this, when we're talking about microscopy, having a national slide bank that is well maintained is also part of this process. Now, when you're transitioning from control to elimination, in countries we see, for example, in Malaysia, or we see in even Vietnam, when cases are very low, maintaining a national slide bank is not possible because cases are so low. So this is where I think regional collaboration is important and sharing of this through our collaboration centers. So this is one thing that WHO can continue to support. What has not been mentioned, I think, on the efficacy front, drug efficacy, surveillance is the capacity at the molecular level to maintain that. And I think there's an opportunity when countries are transitioning to elimination, cases are low, still monitoring this drug efficacy through integrated drug surveillance, IDES. So I think this could be combined with other genetic molecular outcomes through a simple blood spot. with a blood spot during cases in low transmission settings. It has a multi-purpose use. So I think that's something in the transition period for national labs to consider. I'll stop there. Thanks.
Thanks so much, James. Unfortunately, we are going to need to wrap up and not have time for further Q&A, but I would like to give time for our co-chair, Miriam Carter, Counsellor-Health from the Australian Department of Foreign Affairs and Trade, to just do a brief wrap-up of this session and close our final technical session. Thanks so much.
Great. Thank you so much, Professor Robinson. Thank you so much, colleagues. I, of course, have the privilege now of summarising the last session on the last day of what has been a rich discussion over the past couple of days. I think you'll all agree that we've rounded out the conference with on a positive note and with great cause for optimism. I'm going to keep it very brief because I can see there are some dignitaries arriving. I will acknowledge, though, that in preparing for this session, I did keep reflecting, as I think we all have, on the words of the late Dr. Makita, which were that funding for malaria is an investment and not an expense. And I think that's been exemplified by this particular session this afternoon about lab diagnosis and the really crucial role that it plays as an early warning system, not just for communities, but to ensure that that early diagnosis improves outcomes for individuals, which I think is what drives us all here. We set the scene, of course, with Dr. Kelley, who provided some regional updates, and I acknowledge, as always, the really important work that WHO does in providing that technical leadership to support countries to set their own course. You've heard, of course, about some of the challenges, but also the great progress being made here in PNG and the really exciting juncture that we're at the moment with the establishment of a national reference laboratory. So we're enormously fortunate to be in a position with excellent expertise in country, as you've heard from PNG, IMR. That expertise I took away from the discussion just then. It's really practical, it's really targeted, it's really contextualised. I think that's an enormous opportunity for the country to harness. Of course, joined by Professor Gao from China, who have such an impressive story of malaria elimination to share, and as acknowledged in the opening by Mr. Wai, I'm grateful for the work that we do trilaterally here in PNG, together with China and my own country of Australia, to bring that expertise to bear, and proud that collaboration meant that last year 95% of suspected malaria cases in PNG did in fact receive a parasitological test. So on that note, thank you so much to our distinguished panellists. I think this was a great showcase of regional partnerships and that collaboration that is getting behind local leadership and driving outcomes, and thank you so much.
Thank you.